Assalamualaikum. I am Iman Natasha Sofia and we are from Group 2 DBN4 and today I'll be presenting and explaining on gastrointestinal system or digestive system, functioning tests and also laboratory findings. Before we start further, I would like to briefly explain on the anatomical structures of digestive system. And please take note that this is just a brief recap on the GIT system. As we know, animals have two types of digestive system, which are monogastric digestive system and also ruminant digestive system. For monogastric, it has only one stomach, and for ruminant digestive system, it has four stomach, which are abomasums, omasums, rumen, and reticulum. The main differences between ruminants and monogastrics are monogastrics only have one compartment to their stomachs, whereas ruminants have four compartments, like I said, rumen, reticulum, omasums, and also abomasum. So I'll start with the monogastric digestive systems. Monogastric digestive system begin with the ingestions of the food into their mouth, and the tongue and the teeth are gathered together, gathered the feed and break it down into smaller pieces in order to make it easier for the animal to digest the food. And then the food travels down the esophagus, which is a long tube that carries the feed from the mouth to the stomachs. And the stomach serves as a reservoir for short-term storage and digestion, where enzymes break down the feed components so that they may enter and be absorbed into the circulations. Any remaining undigested food travels into the small intestine, where it is broken down further. After the small intestine has removed all available nutrients from the feed, the remaining material is passed into the large intestine and finally excreted from the body through the rectum or anus. As you can see, there is only one stomach, hence why it is called monogastrics. And examples of monogastric animals are horses, chickens, pigs, and many others. And next, I'll proceed with the ruminant digestive tracts, and you can see there's four compartments of the stomachs. And as we know, the ruminant has four stomach compartments, and the largest one being the rumen or first stomachs. It is in the rumen that large populations of microbes eat the breakdown and digestions of the plant cellulose material and mainly cellulose. Thus releasing the available nutrients, and it has a constant movement, effectively mixing the food and saliva together. Any disruptions of these microbe populations of the rumen can cause serious diseases or serious consequences, and any sharp fragments or materials in the diet, such as stones, pieces of wire or nails or anything that is sharp, will drop into the reticulums, the second stomach, thus protecting the more delicate fourth stomach or abomasums from any damage. And the third stomachs or omasums effectively dries the rumen content by absorbing moisture. The abomasum is the equivalent of the stomach of a single stomach animal, for example man, and allows food material already broken down in the four stomachs to be acted on by gastric enzymes. Further passage of the food through the gut stimulates the secretions of pancreatic juices and bile, both aiding in digestion processes. And following absorptive process in the gut, and feces will appear, and normally in pellet form. So that is all from me. Thank you. And my rota mates and my group mates will further explain regarding the laboratory findings in the gastrointestinal tract. Thank you.
Guys, I am Kanmani, and you are going to explore about common clinical signs and common laboratory findings associated with gastrointestinal disease. I am going to focus on gastrointestinal disease findings that is not associated with pancreatic diseases. So, let's start with the common clinical signs that is usually manifested by the animals. They may exhibit one or two or all of the clinical signs in relation to gastrointestinal diseases. The clinical signs of gastrointestinal diseases are diarrhea, vomiting. The animal may appear lethargic with or without signs of inappetence, and some animals may even lose body weight or emaciated due to prolonged inappetence or in a case of chronic gastrointestinal diseases. Last but not least, animal will also exhibit signs of pain such as vocalization due to abdominal pain when the abdominal of the animal is stimulated with a stimulus. There are some other clinical signs that the animal may manifest in the cases of GIT diseases. However, these are the common signs that we can usually observe in GIT diseases in animals. Now, let's move to the common gastrointestinal diseases and its suggested laboratory test finding. GIT diseases can be divided into two categories: infectious and non-infectious diseases. Infectious GIT diseases are usually caused by infectious pathogen. In infectious diseases, there are bacterial diseases, viral diseases, protozoal diseases, fungal diseases, and parasitic gastroenteritis. As for the non-infectious diseases, it is usually cause GIT problem due to metabolic disorders, malnutrition, traumatic injuries, neoplasia, and congenital disorders. Well, next, let's move to the suggestive laboratory findings in serum biochemistry tests and complete blood count associated with gastrointestinal diseases. First, let's talk about infectious gastrointestinal diseases. As in the case of infectious gastrointestinal disease, there will be inflammatory leukogram with marked neutrophilia with red chief, marked lymphophilia, and monocytosis. As in the case of parasitic gastroenteritis, there will be inflammatory leukogram with an addition of marked eosinophilia. And in bacterial diseases, if there is high serum folate concentration and high serum cobalamin concentration in the serum biochem, this finding is highly suggestive for overgrowth of bacteria and gastrointestinal tract in the case of GIT problems in animals. There will be marked hyperglobinemia in serum biochemistry result, as this would highly suggestive for infectious gastrointestinal disease or infection. Hyperglobinemia is due to antibody response to combat the infectious pathogens. While as for the non-infectious gastrointestinal diseases, the CBC and serum biochemistry findings will be as follows. There will be stress of physiological leukogram with neutrophilia, lymphocytopenia, and monocytosis. As in the case of food allergic problem, there will be basophilia. As in non-infectious gastrointestinal disease, it will usually cause malabsorption or malnutrition can cause hypoproteinemia with hypoalbuminemia due to the malabsorption of the nutrients by the intestine. And to be noted here, there will be no marked hyperglobinemia in non-infectious gastrointestinal disease because there is absence of antibody response. Well, gastrointestinal diseases that causes hemorrhages or blood loss, the complete blood count findings will show low hematocrit, low RBC count, and low hemoglobin, which indicates the animal is having anemia. Besides that, in the CBC, there will also less platelet count, which is also known as thrombocytopenia. Well, in a case of infectious diseases that causes blood loss, we can observe inflammatory leukogram with anemia, while in non-infectious gastrointestinal diseases, we may see anemia with stress leukogram and with absence of CBC and complete blood count. Urinalysis also helpful in ruling GIT diseases, as absence of proteinuria in urinalysis is highly suggestive for GIT disease, not renal disease, in animals showing GIT clinical signs. Finally, in animals with gastrointestinal tract problem only, will show normal parameter of other organ functions in the serum biochemistry test. I hope you have some picture of how clinical pathology laboratory tests such as complete blood count and serum biochemistry tests is helpful to rule in possible diseases, as in this video highly suggestive for gastrointestinal tract diseases for the animal that showing gastrointestinal clinical signs. Anyhow, for a confirmatory diagnosis of gastrointestinal tract diseases, we need to do further diagnostic workup.
Hello and Assalamualaikum. I'm Muhammad Haziq bin Ismail from Group 2 Div M4, and I'm going to be talking about the method or techniques to diagnose GIT disease in clinical pathology. So in clinical pathology, GIT problems can be diagnosed through hematology or CBC, serum biochemistry, fecal analysis, and also urinalysis. For complete blood count or CBC, blood sample can be collected by using EDTA tube, which is lavender or pink in color. This tube prevents clotting by binding calcium. And after blood collection, CBC must be done within 24 hours to prevent blood lysis, which can cause the blood cannot be counted for cells. And for the parameters, for erythrocytes, we check for the RBC, hemoglobin, PCV, MCV, MCHC, and reticulocytes count. For white blood cells, we check for the leukocytes, neutrophils, lymphocytes, monocytes, eosinophils, and basophils count. For coagulation, we check for the thrombocytes count. For plasma protein, it can be measured by using refractometer. While iteracy index, it can be observed by looking at the color of yellowness of the plasma. For serum biochemistry, blood sample can be collected by using heparin tube, which is green in color. This tube prevents clotting by inhibiting the thrombin and thromboplastin. Serum biochemistry helps in testing for some organ functions such as kidney, liver, and in this case, GIT as well. It also helps in evaluating the acid base and electrolytes like sodium, potassium, and chloride. Besides, it checks for the total protein in serum, which might help in diagnosing protein-losing gastroenteropathy. For fecal analysis, stool or fecal sample needs to be collected first. In microbiology, the stool sample is cultured to detect presence of microbes. Besides, the feces can also be examined through coprological examination to detect parasites. Some coprological tests can be done are fecal smear, fecal sedimentation, fecal flotation, and also McMaster or fecal egg count.
Hello, I'm Ilya Anatifa Ika binti Ismail, D17A0011. Next, I will be talking about urinalysis. Urinalysis can be used to help define the differential list generated from the physical examination. And there are several ways to collect urine, such as collection during spontaneous micturition, manual compression, catheterization, and cystosynthesis. For urinalysis, we can do physical examination, chemical examination, and microscopic examination. But today, I will be talking about physical examination and chemical examination only. For physical examination, we usually perform it by just using the naked eyes, there we can observe the color, odor, volume, and density. Of course, odor you have to smell it, right? Okay, so for color, normal color of urine is described as yellowish in color. However, the color might be altered by drugs taken, food sources, and disease. Next is the odor. The normal smell can be described as urinoid. However, the abnormal smell, such as ammonia, is said that due to decomposition by bacteria. Next is the volume. We must know the average urine output of each species. Thus, from there, we can now know the occurrence of, for example, oliguria, where the urine amount is less than the average output, average amount. Okay, lastly, for the physical examination is the density. We can measure the specific gravity of the urine using the refractometer. Next is the chemical examination. Chemical examination can be done during dipstick test, which is the quickest way to test urine by dipping a special treated paper strip into the urine sample. It can measure several things such as pH, ketone, glucose, and protein. Here, I want to focus on the protein. Okay, as we know, normally protein is usually found by only small amount in the urine. So, high amount of urine, protein in the urine indicate abnormality. So, which can be caused by many factors. Therefore, urinalysis might help in further evaluate causes of low protein level, especially albumin, whether due to GIT problem such as gastrointestinal parasitism or protein loss through the kidney. That's all from me. Thank you so much.
A good day to everyone. I'm Lim and I'm going to talk about the parameters of gastrointestinal system and its interpretation. For gastrointestinal system, there are three major yet common laboratory tests that can be done, which are the complete blood cell count or CBC, serum biochemistry, as well as urinalysis. For CBC, we will draw the focus to the erythrogram as well as leukogram. For erythrogram, we need to evaluate the packed cell volume or the PCV for the evidence of anemia. Total protein concentration need to be evaluated as well. This is because the anemia can be masked by dehydration, and animal with diarrhea is prone to dehydration. For leukogram, there might be presence of inflammatory leukogram due to the inflammation occurring in the gastrointestinal tract. There may be presence of less shift neutrophilia, and lymphopenia is often associated with protein-losing enteropathy. For gastrointestinal parameter in serum biochemistry, there are three parameters of interest, which include the folate, cobalamin or vitamin B12, as well as alpha-1 protease inhibitor. Folate assessment is an assessment of small intestinal bacterial growth or suspected malabsorption. As bacterial number increases, serum folate increases due to increased bacterial production. Folate is also produced by normal enteric bacteria. It is absorbed in the distal duodenum, thus decreased folate level can or may associate with malabsorption in the distal duodenum. Serum cobalamin or vitamin B12, the level allowed the assessment of small intestinal bacterial overgrowth or suspected malabsorption. As bacterial number increases, serum cobalamin concentration will decrease because of the bacteria interfering with the binding of cobalamin to the intrinsic factor and inhibit its absorption into the circulation. Absorption of cobalamin takes place in the ileum, thus decreased cobalamin level may indicate abnormalities in ileum. Serum folate and cobalamin level can be interpreted together. If there is increase in serum folate level but decreased cobalamin level, it is indicative for small intestinal bacterial overgrowth. However, if there is normal serum folate level and decreased cobalamin, then there can be lower intestinal dysfunction, such as malabsorption, increased mortality, mucosal infections, and chronic inflammatory bowel disease. On the other hand, when there is decrease in folate level but the cobalamin level remain normal, it can be indicative of intestinal dysfunction or proximal small intestine dysfunction. If there is decrease in both folate and cobalamin level, there can be long-lasting of intestinal disease of the entire intestine. There can be chronic inflammatory bowel disease or severe infectious processes causing diffuse malabsorptive disorder as well. However, we need to take note that anorexia can cause depressed serum level of both folate and cobalamin simply due to decreased dietary intake. Alpha-1 protease inhibitor assessment, it is a newly developed assay to assist in the diagnosis of protein-losing enteropathy, such as infectious bowel disease, intestinal lymphoma, lymphangiectasia, and histoplasmosis. This is because alpha-1 protease inhibitor, it leaks into the intestinal lumen in protein-losing enteropathies, and it allowed the detection of disease before the protein loss is severe enough to cause hypoalbuminemia or panproteinemia. Last but not least, urinalysis can be carried out to rule out protein-losing nephropathy if protein-losing enteropathy is suspected. Urinalysis helps to determine the urine protein to creatinine ratio. In healthy dogs, the UPC ratio is usually less than 0.5. If the UPC level fall out from the normal range, it can be indicative for renal disease. However, we need to take note that the active serum sediment can also have a mild increase in the UPC ratio in the absence of glomerular disease. And that's all from me. Thank you.
Assalamualaikum. My name is Amirul Shafiq bin Nazmi and my metric number is D17A0003. I will talk about abdominal cytology, pleural effusion. We can classify effusion into 6, which are transudate, modified transudate, exudate, chylous effusion, hemorrhagic effusion, and also neoplastic effusion. For transudate, in the cytology, we can see mixture of non-degenerate neutrophil and macrophage. There is also presence of low number of small lymphocyte and mesothelial cell. If lymphocyte or plasma cell may be seen, and also it has minimal erythrophagia. For modified transudate, it is almost the same with transudate, but the difference is modified transudate has high total protein than transudate, and also it has presence of erythrophagia and hemosiderophages. Next is exudative effusion. In cytology, we can see neutrophils may dominate, which indicating suppurative inflammation. But if there is present mixture of neutrophil and also macrophage, it indicating inflammation only. Protein crescent may be seen when the protein is quite high, and also low number of mast cell, eosinophil, and reactive lymphocyte or plasma cell also can be seen. For chylous effusion, we can see high proportion of small lymphocyte. Both macrophage and neutrophil also may have clear discrete margin with cytoplasmic vacuole, and low number of large lymphocyte and plasma cell or reactive lymphocyte also can be seen. Next is hemorrhagic effusion. In cytology, few platelet may be present. We also can see reactive macrophage with phagocytis, erythrocyte or intracytoplasmic hemosiderin or hematoidin. Lastly is neoplastic efficient. Actually, there are no particular numerical parameter for neoplastic efficient. However, the total protein of this fluid is typically high. These fluids are often inflammatory and may also have evidence of hemorrhage. There are two types of neoplastic efficient, which are lymphoma and carcinoma. For lymphoma, in cytology, we see homogeneous population of large lymphoblasts with moderate amount of basophilic cytoplasm and nuclei which ranging from 1.5 to 5 times the size of erythrocyte. The chromatin pattern is typically diffuse and nuclei may be prominent depending on the type of lymphoma. For carcinoma, in the cytology, we can see criteria of malignancy, which are anisocytosis, anisokaryosis, multiple bizarre nuclei, mitotic figures, and etc. So this is the table to conclude for the abdominal cytology for pleural efficient.
Assalamualaikum. My name is Afdaluddin bin Hassan. My metric number is D17A0017. Okay, today I will gonna summarize about this topic. As a for summary, we can conclude that for the GIT there is a few diagnostic workup that can be done, such as a complete blood count, serum biochemistry, fecal analysis, urinalysis, and cytology. For the CBC, it's divided into two indicators, which is a erythrogram and a leukogram. For erythrogram, we can see whether the animal having anemia or dehydration. As for leukogram, we can see if there any presence of inflammatory leukogram or not. As for serum biochemistry, their parameters are folic acid, cobalamin, and alpha-1 protease. For fecal analysis, it is important to identify whether the animal having parasite-related disease. For urinalysis, it determines whether there is a presence of protein and creatine in the urine. For example, in the healthy dog's urine, protein and creatine ratio is less than 0.5. For abdominal cytology, we also can see that there are several classifications for effusion. Each effusion has a different cytological characteristic and different indication. That's all from our groups. Thank you.